GPEP UK ECG workshop. From my knowledge, this is the only this is of its one of its kind workshop, which is for full 1 day, and it is completely online, and it is being taught by consultant cardiologist and by myself. Now, as you already have attended the morning session, which was long day, almost more than 60 ECGs were taught to you by a consultant cardiologist, Dr. Saqib Ghani. And I hope you guys have enjoyed. You learned a lot, and I was in the session, and I saw how interactive the session was and how much you enjoyed. After learning the basics and knowing all the ECGs, I think the job for me is now very much easy. And I just have to show you the ECG from emergency perspective, how an emergency physician should look at the ECG and how quickly they can make the right decision. So we'll run through some scenarios where you have to quickly look at the ECGs and you have to make a diagnosis and tell me how are you going to treat that patient. So we'll try to keep this as much interactive as possible. So let's look at this session. This is just last 1 hour of our workshop. I already given you my brief introduction. I graduated from Pakistan and Buckeye Medical University. 10 years as an A&E doctor, 4 years as an EM consultant. My academic background, as you already know, that I've been teaching MRCPs, MRCS, MRK, MFRK, and FEBM and PLEB for almost all my life. Taught and trained more than 5,000 IM doctors, IMGs in UK. I had an opportunity to work in London's best hospital, Royal London, St. Thomas's, Mid-Essex Hospital. I'm the founder director of Pakistan Emergency Medicine Association's London Clinical Courses and Pakistan Medical Career Counseling and GPEP UK Education Project, along with my co-partners and directors, Dr. Salman and Dr. Shisham, and Dr. Saqib Ghani and other senior doctors as tutors. So this is our brief introduction. These are my few picks from my academic activities, which I am doing all across Pakistan, Dubai, Saudi Arabia, Egypt, and United Kingdom. So before I go further, I always love to teach you how the normal ECG looks like. I think Dr. Saqib has taught you comprehensively. So this is what the normal ECG looks like, isn't it? You all know that we have a P wave, QRS, PR interval, QRS durations, T wave. So that's all been taught by the consultant cardiologist. You all now have an idea about the axis. You know the role of lead AVR. You already know how the lead V1, V2, V3, V4 should appear. You have a very fair idea about the QRS progression. You now know how to identify ectopic beats and normal beats. So you are all happy with the normal ECG, yeah? Can just few of you say yes, or if there's any query?
Yes, sir.
Yes.
Yes,
Yes, sir.
Yeah.
good.
Yes, sir.
So we all know what is the normal ECG. Now I'll go through those ECGs which has actually caused some problem to us in our past, and we have learned from it. As an emergency consultant, we looked into it and we thought it is something else, and it was something else. So who is the first person who will tell me this ECG? Anyone raise your hand and just start. Who is this person? Can you please just tell me your name?
Hello.
Yes, who wants to say about this ECG?
I am Tufel.
Inferior volume.
Good. So what's the name of this doctor who said inferior volume?
Dr. Tariq.
Okay, Dr. Tariq. So as you can see that what are the changes? What is the way Dr. Saqib taught you how to interpret ECG before you say inferior volume? How to comment on ECGs? This is important, isn't it?
Yes, sir.
So
Rhythm, rate.
yeah. What do you think about the rhythm?
Sinus rhythm.
This is sinus
Regular.
rhythm. Yeah,
Yes,
regular.
regular.
Yeah.
And ST elevation.
Where is the ST elevation?
Seen in lead 2, 3 AVF.
lead 2, 3, AVF. Yeah, very right. So this is inferior wall MI. And what about this?
Yes.
You can see ST elevation lead V1 and V2 as well, isn't it?
Yes.
Yes, sir.
Septal changes.
Inferior lateral. Inferior lateral. No,
So-
inferior lateral.
No lateral.
Okay.
Inferior septal. Yeah.
Now my question is to all of you about this ECG. What do you see in this ECG? Is an ST elevation MI? How are you going to treat it? What are you going to do to this patient?
Give ACS and then
Yeah.
plan PCI.
Good. ACS protocol and
As it is
PCI.
an inferior wall MI, yeah, we will go
Call to
back to
cardiologist
ECG.
and send patient
Where?
for
Okay,
cath lab
so
to cath lab.
very good. There's no doubt about it. This patient will need PCI. He needs to go to cath lab. But before going to cath lab, someone said ACS protocol.
Yes.
He's got a central chest pain. What ACS protocol you are going to do for him?
Nitroglycerin sublingually, clopidogrel, aspirin 300 mg and 300 mg clopidogrel, and injection happen in subcut
Yeah.
1 cc.
Very good.
And painkiller,
So
any painkiller, morphine to relieve
morphine.
his heart pain.
So you said aspirin, sublingual GTN, and
Yes.
ACS protocol, aspirin, clopidogrel, and pain relief. Do you all agree with that, guys?
Dr. Ashfaq, usually nitroglycerin is contraindicated in inferior wall MI.
Not inferior wall MI. It's not contraindicated in inferior wall MI. It's only be cautious in the right wall MI. So now I'll come to this point. So if you give GTN to this patient, make sure that you ask what is the blood pressure of the patient.
Yes, exactly.
So
BP.
his blood pressure is 100 over 60 or 100 over 80 or 110 over 60. There is one thing important in this ECG. What I want to mention is, and I said about this in my previous talk as well, that whenever you see the inferior wall MI, you always look at lead 3. Yeah. When you look at the lead 3 and lead 2, see where is ST elevation more? Is it in lead 3 is it more, or is it on lead 2?
Lead
In
3.
three.
So whenever you see lead ST elevation in lead 3, which is more than lead 2, always suspect that this could be the inferior wall MI with the lateral wall as well. And you can see the reciprocal changes as well here. And you can see ST elevation lead V1, V2. Now, what I would say, if you want to confirm the lateral wall MI, you need to, when you see this lead, you ask the nurses to get the V4 right side lead. You ask them to get the lead
Yes,
V4
V4.
on the right side. Can you see that V4 now? There's ST elevation in lead
Yes.
V4, which was not there before. Can you see that?
No.
Yes.
Yeah, in lead ECG1, it wasn't there. In ECG2, it is there. So how are you going to do that? You will ask the nurses to place this V4 lead instead of from here. You ask them to apply on the right side on the mid-clavicular line. Now, be honest, how many times in your lifetime have you ever done that?
Never.
Not even a single.
Yeah. So I'm
Never.
sure none of you have ever done that. So you know why
Yes.
we don't do things, because we don't know them. Now, if you place this lead here, sometimes the nurses will be, more curious why this doctor is asking so many funny things to do. So you place this lead here. Now this lead is looking at the right ventricle from here, isn't it? It's like it is exactly in front of right ventricle. And then this lead will show you the ST elevation lead V4 as well. Now, why is this important? This is really very important because I've seen in my practice, not even in Pakistan, even in United Kingdom, If you give the GTN to patients on the right ventricular infarct, they lose their cardiac output straight away and they go into cardiac arrest. All right. So, as per the ECG lead, this ECG was sinus rhythm, heart rate was 84, axis was normal. There was an ST elevation, lead 2-3 AVF. There were reciprocal changes. And if you see that, what are the signs of right ventricular infarct? If you see ST elevation lead 3 more than 2,
Then place it before.
then you need to think this could be the right ventricular infarct. You have to place the lead on the lead V4 to confirm the right ventricular infarct. Now, why the right ventricular infarct is important? Because normally, if patient has a blood pressure of 100 with the ST elevation MI, if someone has got a hypotension, how many of you will give them a fluid?
Everyone.
I will give.
No. If the patient is in cardiogenic shock, you are worried about cardiogenic shock, isn't it? Because someone has ST elevation MI, you will be worried to give him a liter of fluid, 500 ml of fluid, isn't it?
Yes.
Yes.
So exactly, and that's what happens. But in right ventricular infarct, you can give them a fluid. That's the treatment different from left ventricular infarct. So you have to give the fluids to them. You can give them a fluid bolus, and they are very sensitive to the preload, and they can have an exaggerated hypotensive response to nitrates. So nitrates can actually kill them. Are you with me?
Yes.
Them fluids in right.
So in right ventricular infarct, the treatment is you give the fluids because the ventricle will stretch, Frank Starling forces will apply, and then it will push the further fluid there. If there's no fluid in the right ventricle, there's no blood in the right ventricle, your blood pressure will
Cardiogenic
not come
shock.
up. Yeah, your blood pressure will not come up because there's no fluid there. So this is how this is different. So I thought I should mention this to you guys because number of times, even in cardiovascular hospitals, in the biggest, tertiary cardiovascular hospitals, I have seen people with this and they have given them GTN and the patients die because they lose the cardiac arrest, cardiac output. So is this clear now? Yeah,
Yes.
So,
very
sir,
important.
if the patient has right ventricular infarct with inferior wall infarct, so then we don't give them GTN.
So you with the inferior wall MI, you can give GTN, but be very cautious that if there's a right ventricular infarct, then you should avoid GTN. And how would you know there's a right ventricular infarct? If you see the lead 3 is more than lead 2, then you get the another lead. And then, so just be cautious with that. Is that all right? Let's go and see another ECG, which is important for us in ED. So how to spot the right ventricular infarct? The very first thing it is to suspect. So if you see a patient with inferior wall MI, it is supplied by the right coronary artery, isn't it? And the inferior wall MIs are the most notorious. These patients can go into arrhythmias, as Dr. Sakib told you earlier, that patient with inferior wall MI, because the right coronary supplies the AV node, and patient can go into bradycardia, AV blocks. No, AV node. So AV node is supplied by right coronary artery. And then SA node has got as such no blood supply, it's a spontaneous. But if you see the right coronary artery, which supplies the basically conducting system of your heart, and it supplies the inferior wall, it supplies the right wall, so that infarct can cause arrhythmias. You need to be very, very careful. And if you see ST elevation lead V1, if you see more ST elevation lead 3, which is more than lead 2, then think about that this could be right ventricular infarct, and just keep in mind that you can give the patient fluid and you can avoid GTN. Okay, who is here now? Who was very much vocal in the morning and who think that now they know everything about the ECG? Look at this ECG. Who is there? Shiraz, are you here?
I'm here.
Yes. Can you please quickly interpret this ECG? Because I saw you were saying so many things to Dr. Ghani.
Okay, so it's a sinus rhythm. I can see P waves.
Good.
It's a regular rhythm.
Yeah.
And axis is normal axis.
Mm-hmm.
And then coming on to, so I can see ST elevation changes in lead 2
Mm-hmm.
and AVF
Yes.
Yeah.
and some element in V5, V6.
Okay. So if you don't have these mild ST elevation in lead 2, 3, and V5, say for example, if we have only these changes in lead V1, V2, V3, and
Yeah.
these changes are, if these changes are not there, lead 2, 3, and they are normal,
Yeah.
and if you have only this changes, lead V1, V2, V3,
Yeah.
what would be your management plan?
ACS and PCI?
Let me speak to Shiraz first. So then we'll get the opportunity to all of you to discuss the Shiraz.
Yeah.
What will be your line of action for this one?
So this is not a normal ECG. I would definitely discuss with the cardiology.
Well, and this is what happened in your ward at midnight, 11 o'clock or 11 p.m. So what are the changes here in lead V1, V2, V3? What are these changes?
This ST. It's a concave ST.
ST depression, isn't it?
Yeah.
Yes.
Yeah, all agree? This is ST depression in lead V1, V2, V3?
Yes, sir.
Yeah.
Okay. So how many of you will treat this patient as, what would be your treatment? How many of you will treat this patient as NSTMI, not STMI?
Is the patient having chest pain?
Yeah, chest pain, and his drops are 1,000. And so he's got.
I'll treat this patient as an ST elevation, posterior ST.
STEMI. Posterior ST elevation. Because it's reciprocal changes.
Okay, so someone said posterior, isn't it? I like that.
Yes.
Who was that?
Yeah, it's reciprocal changes for posterior STEMI.
Behind.
So if you look at this, whenever you see, so the take-home message from emergency medicine consultant is, whenever you see ST depression in lead V1, V2, V3, do not just think that this is non-ST elevation MI.
Yeah.
Although there is ST depression, but you need to think that this could be posterior MI. As Dr. Saqib showed the same ECG to you guys, isn't it? If you flip this ECG and you see, you will find out that this is actually ST elevation. So how will you confirm it? You are in the middle of the night, you're in your ward, and this is happening, and you sent this ECG to the cardiologist, and he said, well, there's no ST elevation, or cardiology registrar or clinical fellow. So before you make it confirmation, what will you do? What will you ask your nurses to do?
Apply electrodes to back of the scapula.
Exactly. So you will ask the nurses to apply V7, V8, and V9 leads.
V9.
All right. And when you see this V7, V8, and V9, you will see that this was actually ST
elevation.
ST elevation. Now, will you call it NSTMI or STMI now?
STEMI.
STEMI.
Posterior
And
STEMI.
If you would have missed this STEMI, and if this patient, if you fail to send this patient to cath lab, you will be held responsible. All right. So,
Yes.
was it good? Was it good ECG to learn?
Yes, very good.
Yes.
Yeah, important. Yeah. How to pick this ECGs up?
Very important.
So ST elevation becomes ST depression, because the posterior wall is actually the mirror image, isn't it? Chest electrodes are on the anterior chest, so you can't, you will not see ST elevation in posterior leads because they are far away. They are on the opposite side. It's a mirror image, so you have to go back and put the leads behind to see the ST elevation. And more important thing, look, this Q wave become R wave. If you look at this ECG,
Progression
here, if you look at this
of R
ECG,
wave.
V1 and V2 and V3, how many large square? One or almost two, isn't it?
Yes.
They're quite big. In normal ECGs, you should not have such a big R wave in lead V1, V2. Look at this. If you go on the normal ECG, how big is the R wave here?
Very small.
Very small, isn't it?
Yes.
Yeah.
Yeah.
So, because why they are small? Because which part of the heart is it representing? V1, V2.
Right.
Atrium.
As per
Side.
right. So you know the right ventricle doesn't have enough muscle compared to left. That's why these QRS complexes are small, isn't it? Yeah, in V1 and
Yes.
V2. But now you look at this V1 and V2. What do you think? How big is it? Look at this. You see that? QRS is very big, isn't it? Do you all agree?
Yes.
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 You should not have such a big QRS in lead V2 and V3. This is actually the Q wave from the posterior infarct. This is actually the Q wave. So, Q wave becomes R wave in lead V1, V2, V3. Terminal T waves invergence becomes upright. So remember, posterior MI and right MI, they can snatch your easily. They can take your GMC registration off from you, or you may have to face the court. All right, happy with that?
Are the Q
Yes.
means that it is old in form.
So how to spot this posterior MI? Look at this. Posterior MI is suggested by the following changes. If you see the horizontal ST depression, remember, I think Shiraz picked this up, that this ST depression was horizontal. Normally, you don't have that ST depression. And you have a tall, broad QRS, R waves. And dominant R waves ratio in lead V2. So see, dominant R waves, horizontal ST depressions, then you start thinking of posterior MI. You place the electrode V7, V8, V9, and you will see that there is ST elevation. Happy with that?
Yes.
Yes.
Shall we move to case 3 now?
Yes.
Let's move to case 3 and so who wants to do this one? Qasim Bhatt. Qasim.